So a very warm welcome to one and all, and welcome to the instruction course on periocular aesthetics, case-based skill transfer learning. In normal circumstances, we would have had live sessions, but we would try to compensate for it as best as possible through our talks. So, just an introduction. The instructors for this would be myself, Dr. Kasturi, who needs no introduction, and a young budding, colleague of ours, Dr. Vatsalya, who would be covering certain topics. There is an overview to the course where I would be covering on a new concept called the aging trigger points. Vatsalya would be covering on the consultation decoded. And then me and Dr. Kasturi will be taking you over the non-surgical and surgical periocular rejuvenation techniques. These are some of my disclosures. I'm consultant with AMI India and Asia Pacific, that is Aladdin, and also on board for complications for fillers. And just a brief about myself that I'm a vegan, interior designer by passion, and obviously I love being fit and beautiful, and that's why I think I love the aesthetic industry. Some background of my alma maters and how my journey has unfolded over the years. I'm a fellow from Shankar Nethralaya, then from University of Wisconsin, and then I was fortunate enough to found two companies, which is Foresight Private Limited, which does the super specialty work in Africa and overseas, and also my own brand called Clinica Phi, and you can visit the website to know me better. So to begin with, I'm just going to mention that, which is known to us, is that, aging is a fact of life. We all are going to age sooner or later. But looking your age is absolutely not. It is our choice. So it depends on us how we want to be perceived in this world, as far as the aging is concerned. And most of you may have seen this picture of mine, but just to reiterate on the fact that, aging starts age of as early as 10 years, where you can look at the features in the periocular, perioral area, especially, and see yourself. So you are the best judge to see how you have been aging over the time. And it's like assessing yourself over a period of time to see the aging factors. And the concept of the oval face changing into square and the gravitational forces working more to cause the aging, and I'll be covering that a little later. Of course, it's just for the interest of the beginners who have entered the aesthetic industry that whenever we are dealing with any procedure, we always divide the face into zones or in areas. And the simplest way is to call it as upper, mid, and lower face, and there are specific demarcations. And based on the areas, anatomical areas which it covers, there are different types of treatment modalities which are available. Now, let's focus on the key topic, which is the aging trigger points. Now, see, most of the times what happens is when the patient walks into the clinic and asks you for a treatment, we start targeting on a specific. For example, a patient would walk in and say, I have got forehead wrinkles, please treat it. But the concept is changing to the more holistic approach, and the consultation with Vatsalya would cover is more targeted towards the emotional factor and the good feel factor, the feel good factor. And the basic points which we need to include in when we are talking to our patients is actually, how old are you? It's not a bad thing to ask, because your chronological age, your skin age, and your tissue age is important to understand and differentiate between that. And how old does the patient or the client feels him or herself that he is looking, and looking and feeling. So there are two different aspects of it. And also, when did they feel they looked their best? So most of us now feel that 40s and 50s are new 20s because we are in best of our shapes. So it all depends from the ethnicity and the cultural background. I think this is of paramount importance to understand before we undertake any kind of treatments. Obviously, health markers are very, very important to concentrate before we venture into any kind of treatment, because they not only affect the way the aging is happening, but also the outcome and the longevity of our treatments. Obviously, intrinsic and extrinsic factors, as I mentioned, which includes your genetics, your DNA, and the kind of lifestyle one has been leading. A word upon the facial, sorry for the spelling mistake there, the facial aesthetic units, that it has been divided into initially 7 units and then modified into 12 units, which starts from the frontal, supraorbital, orbital, infraorbital, and so on and so forth. Based on these facial aesthetic units is where the actual aging trigger points are talked about. And when we look at these aging units specifically, what we look out for is the aging signs, which is nothing but lines, fold, and skin quality in the gradation of 0 to 4. So when we look about aging trigger points, we look from up to down, that is from forehead to chin, and laterally from your lateral to the medial side. And we look at the soft tissue aging trigger points and the bony trigger points. That means the soft tissue and the skeletal network, which we know about. So let's look at another format of that. Is that whenever, so this, when I was making, I just took random pictures and videos of mine. So these are not very professional looking, but I didn't want it to look very professional. Is that when we look up, which is against the gravity, everything falls back and, you know, the signs of aging actually reverses, versus when we look down is where the gravitational force will work and we would start to look more aged. So if in a static position, in a dynamic position, and also in a looking down position, the signs of aging are more evident. That means that's the severe aging, or it's a beginning of severe aging, which needs immediate treatment and would help the patient. So let's look at one of my videos where I just took it, where I'm animating. Now my forehead and periocular area is Botoxed, so you'll not see much happening there. And I'm trying to animate as much as possible to see which muscles, which tissue, which zone, which facial aesthetic unit is looking more aged. And as I look up and down, you can see the aging is more prominent. So if I look up, I'm actually grade 0 to 1, but when I look down, it's actually grade 2 to 3. And Rashman was kind enough, my better half, to give me this video. And I forced him to, you know, have this video again, is that when you look up again, you see how his face looks more skeletonized and there is no sign of aging. But when he looks down, you can see the periorbital aging, the malar cheek area, the nasolabial folds getting more prominent. And of course, on animation, there are a lot of signs of aging in terms of the rhytides, folds, and the skin laxity. So what are these trigger points? They are divided into 16 points based on the facial aesthetic units. And we look at them in the 20s, 30s, and late 40s, 50s, which depends on the age of presentation of the patient. So at any age of point, if these points are severe in degree, that is the soft tissue and the bone tissue, one, it needs immediate treatment. And second, if we don't deal with them, then the severity of aging is going to be more, and the treatment hence becomes more and more complex and difficult. So as we all know, the sooner we start, the better we can hold on to the aging process. I'm not going to go into the details because it's too much into detail, and we can have a separate talk, or if anybody's interested, we can have separate sessions for it later. And as I mentioned, we have to look into the tight, saggy, angry, sad, the emotional quotient of it. And this has been invented and promoted by Dr. Mauricio Di Maio, who is, according to me, artist, and who has got into all these concepts of looking at the facial aging and the treatment of facial aging in a totally different concept. So based on the aging, we can divide it into the green, yellow, and red zones. And if it's green, based on the points and the degree, that means you can monitor. And if it is in, there is a grading scale and a nomogram. If it is yellow, most of the points are yellow, then you have to consider the treatment. And if it's red, of course, you need to treat it immediately. How does these points actually help? So these points actually help by early diagnosis and detection of the aging process or the changes which is happening. Early treatment, which is of paramount importance. Delay aging. Now, when I say delay aging, doesn't mean that your natural aging is going to stop. But what it is going to do is it's going to hold on to the skeletal network, the ligaments, the fat in a proper way, because we know that all the surgical and non-surgical treatments do, delay the process of aging. And of course, over a period of time, it's going to decrease the severity. So this is a very new concept which we are applying to both our surgical and non-surgical patients. And there's a long way to go into this. But yes, it has been introduced in the Western world and people are following, especially in the injectable area. So this is about the aging trigger points. And last but not the least, consultation is of paramount importance. As I mentioned, that looking at a wrinkle is not important. Looking at the face in total is important. Looking at a condition is not important. It is important to understand the lifestyle and the background from where the patient or the client is walking in, because all these factors at the end combine together and affect the way one is aging, not only on the face but as well as on the whole, which is concerned. So I would just stop here and I would introduce Vatsala to take it over from here to talk about the consultation being decoded, because I think that's very, very important when we are talking to patients about the procedures and counseling them to get converted and also making them happy over a period of time with our treatment modalities. So Vatsala, I invite you to kindly share your screen and go ahead.
Thank you, ma'am. Am I audible and visible as well? Okay. So I'll be speaking on aesthetic consultation decoded. Now, facial aesthetics and beauty standards vary across society, cultures, and over time. Thus, an individual contemplating a cosmetic procedure may have at times several ideals in mind. Working with these expectations can be challenging and calls for an organized approach. Therefore, there has to be certain steps in the basic aesthetic evaluation, starting with relevant patient history and systemic evaluation, expectations and goals. It is said by several authors that addressing the emotional messages or miscues of the patient's face yields a greater patient satisfaction. So one must aim at reducing the negative attributes of looking tired, sad, saggy, or angry, and try to enhance the positive attributes towards making one attractive, young, more contoured, and more feminine or masculine. Now, photographic documentation as a part of the aesthetic evaluation is very important, both pre-operatively and post-operatively. One can review the photographs of the patients at a younger age, and that will help in identifying the targets. Now, psychological assessment also is extremely imperative because it helps in revealing unrealistic, manipulative, unstable, or even at times certain hostile patients, the results for whom could be unpredictable and their response could be not something that we would be expecting. After this, we must undergo a detailed ophthalmic examination along with a detailed facial examination. The face must always be considered both as a single unit as well as having several components. The periorbital region provides for key features of the face, and eye contact naturally draws attention towards it. Patient history. So among the relevant patient history, we must rule out the presence of thyroid eye disease, myasthenia gravis. We must also conduct a systemic evaluation to establish surgical candidacy, any medications the patient is on, prior refractive procedures to avoid ocular surface damage, prior aesthetic surgical and non-surgical procedures. Amongst the ophthalmic examination, visual acuity, ocular motility, dry eye syndrome, and tear drainage system malfunctions, if any, must be ruled out. Now, we divide the face into three segments, the first being the orbitoskeleton and the globe. The relationship of the globe to the orbitoskeleton is extremely crucial. Facial bones form the framework and the base of attachments for the ligaments and the muscles that define the face. Mid-face comprises of zygoma laterally and maxilla medially. A prominent malar eminence is considered youthful. Aging is associated with resorption of infraorbital rim, leading to malar hypoplasia. Here, what you can see is that when you drop a line from the supraorbital rim to the infraorbital rim, it creates a vector. It's called a positive vector if the cornea is posterior to this line. And with aging, one that goes from being positive to a negative vector wherein the cornea is anterior to this line. Considering the exophthalmos and inophthalmos, one must know that exophthalmos may exacerbate lid retraction to produce a surprised look. And proptosis also increases the risk of post-operative eyelid malposition. While in case of inophthalmos, it may produce pseudotosis and may also cause superior sulcus hollowing, which gives a tired and aged look. The anterior globe prominence can be measured using a Hertel's exophthalmometer. This also aids in surgical planning as a tailored approach towards the positioning of lateral canthus can be sought after in a lower lid blepharoplasty.
Slides, yeah, it's moving, yeah.
Yes, so moving on to the forehead and the upper eyelid complex, these are some of the important surface landmarks of the forehead, brow, and the upper eyelid complex. The parameters in here to be assessed include the sling, rhytids, brows, and eyelids. In case of a forehead, macroscopically one must assess the shape, hairline, hair quality. Receding hairline in male pattern baldness can benefit from pretracheal incisions. In case of eyebrow position, typically in a male eyebrow, it is flat, and for a female, it is arched. We must focus on eyebrow symmetry or lack thereof, along with brow ptosis, which could be as a result of the downward gravitational pull and aging, along with soft tissue laxity. Additionally, frontalis overaction leads to prominent horizontal forehead furrows. In this lady, we'll be able to comment regarding the rhytids. The rhytids are associated with underlying facial muscle contracture. We can see that the horizontal forehead furrows are formed as a result of the action of vertically oriented frontalis. The vertical lines between the brows are as a result of corrugator supercilii action. Horizontal nasal dorsum rhytids or the bunny lines are as a result of the action of procerus. The crow's feet are as a result of the action of the orbicularis oculi. In this video, we can see the eliciting of the dynamic rhytids, and these dynamic rhytids are known to respond favorably to muscle weakening procedures such as chemodenervation using Botox. Upper eyelids, droopy, wrinkled, or tired. Now, upper eyelids independently and profoundly impact the overall facial appearance and expression. So the appearance of upper eyelid as droopy, wrinkled, or hooded can diminish the prior youthful appearance. Upper eyelid dermatochalasis primary is as a result of true age-related excess of eyelid skin. Secondary, as a result of excess skin from sagging of brows. One must also remember that loss of integrity of the orbital septum leads to prominent eyebrow fat pads and displacement of orbital portion of the lacrimal gland, which can lead to puffy lids. Blepharoptosis evaluation in primary case with frontalis relaxed and brow in fixed position is absolutely essential as it alters the surgical planning. One must also note asymmetric lid creases, if any, because it may be indicative of levator dehiscence and will need LPS reinsertion. Now coming on to lower eyelid and mid-face complex. In this gentleman, one can see that there are severe eyelid bags. Now going on to the anatomy, we can see that this is the orbicularis oculi. And these are the surgical landmarks, the lateral canthal tendon, the medial canthal tendon, the tarsal plate, and the orbital retaining ligament. Now with age, we can see that orbital fat herniation is noted. Now orbital fat herniation may contribute to aging phase, orbital septal weakening, orbicularis atrophy, supporting ligament laxity combined inside the orbital fat protrusion. Herein, examination in the upper gaze may assist in identifying problematic fat compartments. The lower eyelid and mid-face continuum in youth exhibits single convexity on lateral view. With age, convexity develops as mid-face separates from the lower lid at the level of the orbital rim. Volume depletion and weakened mid-facial soft tissue support leads to lid-cheek junction contour irregularities such as malar mounds and festoons. We must also evaluate for eyelid laxity. For significant eyelid laxity may be an indication for lateral canthal anchoring to avoid lower lid malposition, lack of thalamus, and palpebral fissure deformities associated with periorbital procedures. To summarize, the critical aesthetic assessment of the periorbital face includes A. The knowledge of periocular and ophthalmic anatomy. B. Understanding of morphological changes associated with age, sex, and race. We must consider the face to be divided into three separate segments such as the orbitoskeleton and globe, forehead and upper lid complex, and lower lid and mid-face complex, because of which we'll
I think
Yeah.
I think we lost her, but I think, yeah, that's fine because she could complete her talk. So thank you, Vatsalya, for, a very informative session on how to go about the tell and tale signs of facial aging and what you should consider before we, take the patient for a treatment. And as I mentioned, it's very, very important to understand the background from where the patient is coming, the expectations, the lifestyle, in addition to what we see anatomically on the face. So, ma'am, do you want to go ahead with your talk, or I can?
I'll go ahead with my talk because they're calling me.
Sure.
I'm the fourth speaker there. Okay. And again, I'll come and join you.
So I have a privilege to invite Dr. Kasturi for her talk on the, the periocular surgeries and the rejuvenation. Thank you, ma'am, for being there.
Yeah. Shubhra, it's my great honor and privilege to be in your course. And this is a course we were longing for. Like, we really wanted to discuss everything about the surgical and the non-surgical aspect. But I believe that both surgery and non-surgery today, most of us going more towards non-surgery because of multiple benefits. That's why I want you to be the last speaker so that you can cover everything in details. But those are some, still there are many indications where surgery is the only option. So I'll be speaking basically about all the periocular surgeries. Can you hear me well? Am I audible?
Yes, ma'am. We can hear you very clearly. Thank you.
So let me start with blepharoplasty, which we all know is a surgical procedure in which variable amount of the eyelid, skin, the muscle, and the orbital fat are either excised, or either it is being redraped or it is being sculpted. It has basically come from the Greek word blepharon, which means eyelids, and plastikos, which means mole. And today it is the most time-tested technique, having both the functional and the cosmetic indication. What are the functional indications basically in epiblepharon and also in dermatochalasis? What we get a lactosis, and because of this lactosis, it can involve the contrast sensitivity. There can be changes in the corneal topography leading to high order astigmatism. But one good thing, this astigmatism is usually with the rule astigmatism, so vision is not much hampered. But however, there are also, we could also in our study also we found there's a high order aberration is much higher before the blepharoplasty procedure, which gets relieved after the surgery. And this is what these are some of the functional indication. And this same paper which has won this IGO Best of the Merit Award this way and this time, and this blepharoplasty is the surgery of choice where you need to redirect these eyelashes. These are the eyelashes touching the cornea, and the same patient you can see just after the operation, you can see so beautifully the eyelashes are being redirected so that the corneal problems are less. And the other indication which I always say is a cosmetic indication where you create a single fold from a double fold, or it may be in the form of asymmetry, like absence of the lid crease, and then you need to operate and have the lid crease in both the sides. Another patient with the absence of the lid crease, where you need sometimes to operate in both the sides to to maintain the symmetry, and that is what you see. Many times we need to increase the TPS because they really want to have a good tarsal plate show so that they can have a better eye makeup. So we need to evaluate on both the functional and cosmetic indication on the basis of the zone, and this zone can be basically a central zone, a medial zone, and a lateral zone. So what do we evaluate in the central zone? This is basically we evaluate for the skin crease, we evaluate for the volume axis and the ptosis, and the most common operation for the central zone is basically a creation of the skin crease from a single lid to a double lid. However, in case of medial zone, the most common indications are the nasal fat bed herniation, the hollowness, and the epicantral fold. And when you have an epicantral fold with the absence of the caruncle, which is not being seen, you need to do an epicantroplasty along with the blepharoplasty also to give an adequate visualization of the caruncle. And the lateral zone is basically for the lateral hooding and also for the broad ptosis, but which we commonly see is basically many a patient on blepharoplasty have a blepharochalasis, and the lacrimal gland prolapse is not so uncommon. So along with the same surgery, you can also manage or reposition the lacrimal gland. So the marking is very important, which is a rule of 10. That is 10 millimeter from the eyelash to the low point of the margin, 10 millimeter from the eyebrow to the upper point of the marking, and then approximately 10 millimeter from the lateral part of the eyebrow. But also in elderly patient, you can also reduce to 8 to 10 millimeter because the skin is not tight, it is very loose. So even if you have approximately 8 millimeter, it does not cause much of lack of tenderness. Sometimes if you have an epicantral fold, and to prevent the medial webbing, we also, instead of having a crescentic incision, we also give an extension here medially, which really helps in many of the Asian eyes. So central blepharoplasty, which I have already mentioned, the most common indication is the creation of the lid fold, redirect the eyelashes. And this is what especially the people from East Asian configuration where there's the absence of lid fold. Most important is that you should have a very even marking, and in spite of doing the best of best marking, there can be something asymmetry of the lid crease post-operatively, because every human being, the healing is different, and even tissue in the same body, it has a different type of healing. So this is how we excise the skin, we excise the muscle, then we expose the fat, and once the fat is being exposed, that we titrate how much amount of fat is to be exposed, and once the fat is being exposed and excised, then we form the lid crease formation, which goes skin, orbicularis, tarsus, back to the orbicularis and the skin. So you need to fix the skin to the tarsus in order to have a very prominent lid crease, and ultimately this is being followed by skin closure. And this is the end of the surgery. You can see the eyelash being directed upwards and the other unoperated eyelash not yet being directed. And these are some of the patient post-operatively you can see where there's so beautiful creation of the lid crease in the different gaze and the different views, and especially like this lady where they really wanted lid crease formation in a single eyelid. And also only if you give the lid crease formation and also you fix the skin orbicularis to the tarsal plate, you can have a very long lasting crease, as you can see here, and also some other patients. Sometimes they want a very small crease. It is more difficult to make a small crease as compared to a bigger crease, and these are the situation you really need to do a very meticulous dissection while you do the surgery. Many times this elderly patient, they have some amount of ptosis, and if you do a phenylephrine test, it usually comes to the positive. So this type of situation in the blepharoplasty, we also do a ptosis surgery, which is always we call as a blepharoplasty combo, where what you do along with the blepharoplasty, we do a MMCR where we measure the amount of the molars and the conjunctiva that needs to be resected. Approximately 8 millimeter of MMCR MMC corrects approximately 1 millimeter of ptosis. Then I usually put a Putterman clamp and also give a double row of the sutures. And once you give a double row of suture, usually a PTS, and also you try to exteriorize the knot outside. And these are the results that you can see: a blepharoplasty combo, a ptosis surgery along with the blepharoplasty, and you can see a lid crease and also lateral hooding, and the ptosis also not there. Supposing sometimes if you have a real big ptosis and the phenylephrine test negative, then these are the situation you can do either a LPSR, or if it's a small ptosis, you can also do application. In the lateral zone, the most common is the lateral hooding, which I'll be coming to in details, but also one of the most common is the lacrimal gland prolapse, which I have already shown, like this girl having so much of blepharochalasis and the lacrimal gland prolapse. So these are the situation where along with the upper lid blepharoplasty, you need to reposition the lacrimal gland. So the section of the orbital septum will expose the lacrimal gland, also the fat, and you can see the lacrimal gland is much paler. It is a whitish as compared to the fat out here. And then you can use a different type of suture, you can use a polydec, you can use a polyester, where you pass the suture through the lacrimal gland capsule and the surrounding tissue, and the next suture should be passed through the periosteum. Like you should really pass the suture well and try to reposition the whole of the gland deep into the orbit, and this is being followed by titrated amount of the fat being excised. And she already has a very good lid crease. You do not have to give a lid crease formation suture. And once you give the suture, your lacrimal gland is being fixed, and you excise the prolapse fat, and also then you go for the skin closure. And this is how she looks post-operatively, and you can see this is the pre and the post following the blepharoplasty combo. That is a blepharoplasty with a lacrimal gland prolapse being repositioned. If you have a young lady like this with so much of lateral hooding, I think in such situation, blepharoplasty with a brassiere suture, it really works good. And this is how we put the brassiere suture. We pass the suture through the orbicularies and lower orbicularies, then the upper, and also the marginalis, arcus marginalis. So once you pass through it, usually you can pass 2, 3 suture, maximum 3, but I think 2 is sufficient. And then you can really go for a very good correction, like with so much of hooding. But only thing that immediate post-operative period, the patient becomes really fussy at times when they see so much of healing. It doesn't look good in the immediate, but after a month, she looks much better. That is how you can see. This is the same patient pre-operatively, and this is the patient post-operatively blepharoplasty with the brassiere suture. And when you have a droopy hood like this with so much of extension, then you have to do extended blepharoplasty. Only difference with the conventional aesthetic blepharoplasty is that you need to go beyond the lateral canthus, as you can see here, and you need to put the point number C at the lowest point of hood. So the rest of the incision is same, only the difference is that you have to go beyond the lateral canthus, and also in the incision you need to cover the whole of the hooded area, and then the rest of the procedure same what you do for a normal aesthetic surgery, which all the details you will get in this article, which was published in IGO approximately 2 years back. So this is how you see the incision extends much beyond the lateral canthus, which is as opposed to the aesthetic where the incision ends somewhere just in front or before reaching the lateral canthus. And these are the results, comparatively good results you'll see with the extended blepharoplasty. Sometimes along with it, if the hooding is not much, you can go for just internal bropexy, where you need to fix the orbital roof and the subcutaneous tissue approximately 1 centimeter above the superior orbital limb. Usually I use a 4-0 suture exposed down to the periosteum and pass a horizontal matrix suture fixating it to the periosteum. So these are the results that you can see. Like if you do a bropexy, you can really give a good lift. As you can see a lady here, initial phase it looks little more, but I think it's much better than what she was pre-operative. Sometimes you have a very tautness of this corrugator muscle, so you need to excise the corrugator, because if you give a lateral give, the tautness becomes much more. So here, along with the blepharoplasty, you can see I'm excising it down to the periosteum to do an internal bropexy. And once the internal bropexy is done, you expose the corrugator group of muscle. You excise the corrugator group of muscle, but one thing is that you do not leave this area empty, because if you leave this, it leads to scarring. And this can lead to a nicking, which I have learned from my own experience. So the fat that you will be excising from the upper lip blepharoplasty, the same fat can be used to cover it can be used to cover this pocket that is being seen here. And this is how, like, this is before, and you can see that in the tautness, that hypertrophy or the corrugator is not seen here. When you have a real bad droopy eyes, so how do you do? This is nothing but an extended blepharoplasty. Only thing, if you make an incision like this, that will lead to a lateral pull here. So what I do something, a W type of incision, and this W type of incision, you give incision like this, because then once you suture it, it does not lead to any notching or lateral pull out here. And this is along with the LPS plication, where you can see the 3 sutures which I pass the tarsus plate to the LPS, and you can also correct the ptosis along with it. And this is how this gentleman looks. This is the pre and the post-operative correction of all the quad blepharoplasty, all the foldeds. In the medial zone, the most common indication is for the epicentroplasty. And this epicental surgery is something very simple, where you can just form a crescent. You can cut a crescent of tissue. Like this is the blepharoplasty incision, and the crescentic amount of tissue being excised. And along with the excision of a crescentic, you need to expose the MPL. And once you expose the MPL, you can shorten the MPL, and this is a very simple and an idea of doing a medial cantoplasty. Another way is you give the incision a V, Y, and suture in the V, and at the same time you expose the MPL. And this MPL also, once you expose, you flatten the MPL, you shorten the MPL, and that gives a very good correction of the medial acantoplasty. And you see wonderful results like this. You can see so beautifully correction. The caruncle can be seen so well. And also under the lady, you can see this caruncle can be well. And you also decrease the telecanthus look appearance which happens. A little bit of a lower lip blepharoplasty, we know the main indication is baggy eyes, and today it has become a major concern for all the age, all ethnicity, all elderly people, young people, so much of stress and strain leading to baggy eyes even in young patient, which can be either temporary or permanent. Temporary is basically due to lack of sleep, unhealthy lifestyle, too much of allergy, salt intake, or other systemic condition. But whatever it is, there is an anatomic change. There is a herniation of the fat, which can be hereditary, as you can see in this young girl, or it may be because of age related. It can be because of thyroid eye disease, especially aggravated by smoking. So these are the situations you need to differentiate whether it is only fluid or fluid plus fat. So when the patient looks up, you can, and when they looks down, if you still have this swelling, this is fluid. But if the patient look up and it looks down and you don't have the swelling, this is basically a fat. So you need to differentiate whether it is a fluid or fat, because this would really help you manage in different way. And especially these are all because of the negative vector that occurs in such situation. So what is this positive and the negative vector? Where young, you see the malar plane, which lies much anterior to the corneal plane. And this is the positive vector that we say. But as we age, because of the changes in the maxilla, because of the deflation, because of gravity, because of the hypoplasia of the maxilla bone resorption, the malar plane lies much posterior to the corneal plane. And this is known as a negative vector. So because of this, all these baggy eyes, what we see the stetoblepharon, we see the malar mouse, we see the festoon, and this forms classically the double convex deformity, which we say in the case of baggy eyes. Along with it, there are other aging changes like the horizontal eyelid laxity. There are changes in the dermatochalasis. There can be also tear trough changes. There can be different types of hollows that we see, all related to the aging changes. So what do you manage? What do you say? And this double convex deformity is also characterized by the lengthening of the lid. So this is what you see when we are young. The lids are not lengthened, but we may have a tear trough, we may have a baggy eye. But what happens when we age? The lid really lengthens. So there are different ways how you manage based on the lengthening of the lid. And a very nice paper by Fessa et al., who has shown that if the lid lengthening is not much, less than 13 millimeters, so there you need to only excise the fat. But if the lid lengthening is between 16 to 19 millimeter, you can excise the fat and also fill it either with a dermal filler or with a fat filler. And if it is too high, more than 19, then you need to go for tissue preserving. You need to do a redripping. And this was discussed in the AAO meeting, and he has shown beautiful videos in one of the AAO meeting that me and Shubhra we have attended. And this is what happens, young people coming to you, you can directly excise the fat. This is what you can see, that all the 3 fat particles has been exposed, and one by one I have excised it, because the lid has not been much lengthening of the lid, a very short lid, and she is doing much beautiful post-operatively. Another young girl with has, I think I can continue, Shubhra, for another 5 minutes. Shubhra,
Yeah.
with a lid lengthening, but still with the baggy eyes, and only the fat excision has given a beautiful correction. A young boy, you can say gentleman with a too much of fat prolapse, but his lid lengthening is not there. So what I had done, I had only excised the fat and converted the negative vector to a positive vector, where you can see the whole negativity has been redirected and it has become positive only with the excision of the fat. There's another example. You can see a beautiful effacement of the lid cheek junction with only excision of the fat. But when you have a lady like this with so much of lengthening of the eyelid and so much of fat prolapse, where the fat is much anterior to the anterior lacrimal crest plane, then the only indication is the tissue preserving, that is the lower lid blepharoplasty with the fat repositioning. And this is usually classically done by transconjunctival approach, where you need to release the orbitomalar ligament, and this orbital fat is being transferred, it is being transposed into this SOOF region, so that you don't have this demarcation line. You have a very good effacement of the lid cheek junction, and you need to preserve whatever fat the patient patient is having, because this is basically of the deflation, the gravity, the G force that is working on her. And this is classically done by a transconjunctival approach, as you can see here, where we all know the lower lid, we have got 3 fat beds separated by the arcuate ligament and also by the inferior oblique muscle. And then what I do, you go by transconjunctival approach, but you be very careful of the inferior oblique muscle, because this is the muscle, if you injure, it might lead to too much of diplopia and other postoperative complication. Fashion the 3 pedicle, there's no limit how long you can fashion, the longer and the healthier, and that appears you should have some amount of blood supply to it, it gives a better look. So once the 3 pedicles, fat pedicles are being fashioned, you release the orbitomallear ligament. Once the orbitomallear ligament is being released, then what you do, you transpose the pedicle that you have formed into the SOOF region, or as down as to the maxillary plane that is possible. And then along with it, you can usually tie it with the bolsters that you can see here. And this is a beautiful look you can see before and after operation in the lateral view, in the 45-degree view. And what you see, the negative vector, that you can see the negative, the malleolar eminence so much behind the anterior corneal plane, you can see that the negativity is converted to a positive vector. So this tissue preserving really helps. But in situation like this, when you have so much of scleral show with so much of lid lengthening, lid laxity, then along with the lower lid blepharoplasty, you have to do a canthal repair. You have to do either cantoplasty or a cantopexy. Cantopexy is a close approach, but the cantoplasty is equally good when you do a transconjunctival approach, and you get a very good result. These are some of the examples of the lower lid blepharoplasty with fat repositioning along with the lower cantoplasty. This is by the external approach with the cantoplasty. When you have something like this with so much of stetoblepharon, with malar deflation, with so much of displacement, where the gravitation force has played a big role in the mid-phastosis. So you need to reverse this gravitational force, restore the 3D position of the subunits of the face, and give the volume. And the best way of understanding is that if you look to this paper by Pooja et al., you will see that when the 3D photography of the same lady has been taken in sitting and supine position, you see the difference. This is in the sitting position. She looks so tired. She looks so sagged. She looks so sad. And because of gravity, everything is being pulled down. And this is the same patient 3D printing and also the 3D photography in the same patient in a supine position. Can you see the volumization? The cheek is lifted up. The nasolabial fold is much reduced. So this is also what I have tried in one of my. So you can see here, like when she is the same lady in the sitting position and in the supine position. See the difference. They see the volumization. When she is in the supine position, you can see a big better malar mound. You can also see the position. You can see the jawline here. You can see there's asymmetry. You can see the jawline, which is much better. The tear trough is much better, and also the position of the eyebrow. So this is how you need to counter the G force, especially when you have a mid-facelift, mid-phastosis, as you can see here. And the best way of doing is a very minimal manipulation. You can do a transcutaneous lower lid blepharoplasty that you can do here. Do a transcutaneous, expose the 3 fat bed. You can excise the lateral fat bed. This is the inferior oblique muscle out here. Transpose it down as possible down to the SOOF after releasing the orbicularis retaining ligament. And then the lateral part, what you do, expose the SMAS. And also once you expose the SMAS and the orbicularis, you need to transpose it at a higher level. Sometimes I still remember 2-3 of my patients where I have transposed it as high as to the temporalis fascia, but it is at least the minimum limit should be, which is possible. You can transpose it and fix it at a higher level at the position of the lateral canthus. Along with it, you can either do a lateral cantopexy or do a lateral cantoplasty and excise the excess amount of the skin. And this is how beautiful they look with a quad blepharoplasty and very minimal facelift. In fact, I feel that nowadays we don't go for a very major facelift because this can be very well managed with filler, and Shubhra will be covering it. It has made life wonderful. Like this facelift surgery is such a major surgery with so much of post-operative comorbid issues. So the best way is you do a minimal facelift. You can do a smash lift, you can do a SOOF lift, and rest all this ovalization and rest all the shaping of the lower part of the face. It can be done with a filler. So this is how the same lady who came to me, and this is after all the aesthetic procedure, and who looks much better. So with this, I end. Thank you all very much, and thank you, Shubhra, for this opportunity.
Thank you, ma'am. That was a lovely, lovely talk as always, and beautiful results. I think you have motivated all the people, youngsters, to be proactive in this field, and what an amazing work. Thank you so much. And I think I would wait for you once you're back from your talk.
Okay, go ahead. Huh? Thank you. I'll join you again. Bye.
So I would be now sharing my screen for the rest of my talk. Just give me a minute. Okay, I think I'm finding some issue here, but let me just, yeah. Okay, so I hope my screen is visible and I'm audible. Okay, if someone is there to confirm, otherwise I'll just go on. So continuing with my talk, as Dr. Kasturi has touched based upon the surgical periocular rejuvenation, I would be talking about the non-surgical periocular rejuvenation. And we have known the fact that, you know, as we are progressing into this field, that instead of just lifting, just tightening, we need an overall rejuvenation where we need to plump it back to its original shape, size, and volume. And the best example is of a raisin and a grape. And there are other various examples, but this is the one which I like to give. So there are various tools, as we mentioned, the basic tool which in our hands is injectables. Surgery has been covered by Dr. Kasturi, and there are certain other treatment modalities which I would just touch base upon. So I talk about the various P's when it comes to this treatment, which is the patient, product, protocols and preparation, procedure, physician-related, patients, and practice. So these are the P's I would be touching upon. When it comes to patients, who are your target patients? Practically all patients, unless the patient is having an unrealistic outcome or is not fit medically, and which are NMJ disorders in terms of, the Botox injections, some allergies previously, or aversion for being beautiful is another contraindication which I feel. So the product, as we all know, is botulinum toxin and hyaluronic acid fillers. I have no personal interest in these products, though I am a trainer with Allergan, and one of the other companies. But, you know, these are the products which are available, time tested, FDA approved, and have a lot of literature in place to back you on, with all the data. But there are other soft procedures in terms of cosmeceuticals, chemical peels, dermabrasions, radiofrequency skin tightening, non-surgical facial tightening, combination therapy, stem cells, and so on and so forth. As the technology is advancing, we are having new and new machines for the non-invasive, minimally invasive treatments. I would be touching base upon the Botox and fillers mainly because that's the crux of the talk, as being the oculoplastic and ophthalmic surgeons. So we know that Botox is of type A, B, and, which has been FDA approved for, so type A has been FDA approved for cosmetic treatment, and type B is mainly for the functional. And we all know about how they're present and how they're used. A word upon various types of Botox in the industry. Basically, if you compare it with alcohol, everything has the basic ingredient is alcohol, but the way the alcohol is prepared, processed, and presented is what makes it rum versus an vodka or another drink. So these are called the basics of biologics. So this is based on how it is processed. So based on that, each product will differ from each other. Now, there are some consensus and recommendations, and these have been revised over the years. We have even Indian consensus on injectables, where how do we reconstitute Botox? How do we store? Where do we store the fillers? What is the best product to be used? And so on and so forth. So for Botox, we can reconstitute it with normal saline, non-preserved, and 2 to 8 degrees is where we store it. If it is not constituted, we can store it up to, if it is non-constituted, you can have it in your refrigerator for 6 to 12 months. But if it's reconstituted, within 6 to 8 weeks is what is recommended to be used. Hyaluronic acid, how does it work? It works on the extracellular matrix as a collagen. It works as an artificial collagen, binds water, plumps, rehydrates, and softens. We have fillers for all the levels of the face, starting from the bone remodeling to the fat to the skin hydration. And even now there are fillers with the newer technology where you just put it at one spot and it spreads all over the face to give you the new collagen and vascularity on the face. So obviously we need the tools and the processes in place. I'm not going to go into detail of it. The procedure, I'm just going to touch upon the concepts because, to show each and every technique is, we have short of time on that. Understand the arrangement of the facial layers, where we want to inject, whether it is the superficial layer, intradermal, into the SMAS, into the soft, deep fat pads or the bone. So the facial anatomy is very, very important. Face, there is no safe zone on the face because it's full of vascular vessels, superficial and deep. So it really depends on the anatomy understanding and your techniques, how you do it. Folds are the places where major arteries are present. So you have to be very, very careful, especially we know the supraorbital, the dorsonasal and your labials and facial artery. Infraorbital, all the foramens are in line in the face, which bisects the midpupillary line. So when you're injecting, be careful about that. It is also important to understand the nerve blocks in this area. Skin is a natural barrier. So if skin is erupted, is not fine, there is a barrier dysfunction, please don't inject because that can lead to secondary infections, hypersensitivities, and more complications. The muscular level, the muscles are very, very vascular and active and high on metabolic activity. So keep away from injecting on the muscles or intramuscular. But there is a concept of myo, where we can do myomodulation, where we inject the filler on the muscle. So we're actually creating a barrier or a loading effect on the muscles and play with the agonist and antagonist to work on the facial features. A word on facial lymphatics. Overloading of lymphatics is a big no because a facial lymphatic is a complex structure to understand. So not more than certain amount of filler which has to be injected at a time. You can go into stages and then plan your treatment. Look out for systemic infections, pre-existing infections like dental, sinus, even the urinary tract infections, because they can lead to secondary infections and hypersensitivities in terms of fillers. As I said, please understand your anatomy well. Looking at the complications of fillers, they can be acute, delayed, and persistent. Nothing comes without a complication. So we have to be trained, we have to understand the anatomy, we have to be responsible for what we are doing. And the worst complication could be blindness, but the cases are very, very rare and we have protocols in place to treat that. But yes, lumps, bumps, hematomas, hypersensitivities, infections, inflammations are part and parcel of especially the filler injections. There are papers on avoiding and treating blindness, and especially the central zone is a danger zone. So don't kind of experiment or be very, very, very sporty in doing all these things. So you need to understand your concepts very well while injecting, and because one blindness case and it's really tough to handle. Now, while injecting the Botox on the forehead, there is some concept where we don't want to go too lower because we don't want to inject into the brow muscles and cause the brow ptosis. We want to work on the forehead, the frontalis muscle alone. So stay away from that. If you're working on the glabella, work on your corrugator, superficial and deep head. So based on where the muscle is placed, your injection depth has to be accordingly. Crow's feet, while injecting, people usually go overboard, either inject too much or in different points, go too deep. So be careful about the understanding of zygomaticus major, which is a smiling muscle. So if it gets paralyzed or it's injected, it's okay to do it in hemifacial spasms or blepharospasm, in some cases of blepharospasm. But in aesthetics, it would create a fake smile or an augmented periocular reaction, which is a big no. And we have seen a lot of fake smiles happening. So this is the cadaver dissection where you can see the zygomaticus major actually running down from the corner, from the most prominent part of the zygomatis to the corner of the mouth. So that's the red spot where you're not going to inject. When coming to the teardrop deformity injections, obviously we understand the anatomy. Being oculoplastic surgeons, we don't want to go to medial and too deep because our facial artery is running over there, and most of the blindness cases can happen in that area. So be very, very careful. And also there is an interanastomosis between the two angular arteries, which can lead to even bilateral blindness. And there have been 1 or 2 cases reported in the literature. Physician is important because unless you are trained enough, the complications can happen. And we have to deal with them. So as I said, hematomas, allergies, hypersensitive reactions can happen. So training and knowledge is a must. Patience and practice is the key, because the most complications, skill can be made simple if we have a thorough knowledge. And of course, if you combine all these procedures, which I have not gone into too much detail, but yes, if you can combine, you can actually transform the faces, as Dr. Kasuri has shown surgically, but also non-surgically. So we are venturing more and more into injectables, cosmeceuticals, non-surgical facial lifting. Are these a replacement for surgical procedures? No. So we have to, select our candidate properly, talk about the pros and cons and the, as I mentioned, the trigger points, understand what's happening with the face, and then take a call on which treatment modality is best for that patient. So thank you very much for patient listening and hearing. And I hope this course was useful, and we can continue to do it live next year with a lot of, live demonstrations and, cross questioning. So thank you so much. So I think we come to an end of our course, and Mr. Vinod, if you are there, and if there are any questions, because I don't have access to the questions, if there are any, we can take that up, because we are having almost 30 minutes.
Do you want to have the keynote address played first, or how should we do it?
Yeah, you can play the keynote address, and then I think Dr. Kasuri will be back, and if there are any questions, we can. Yeah, thank you.
Dalchanji?
Yes, yes.
Let's play the keynote address. Thank you.
Okay.
I have no financial interest or relationships to disclose, and I'd like to speak to you about Retinoblastoma 2021. First, I'd like to give credit to the numerous collaborators on the oncology service at Wills Eye Hospital who helped with the collection of many of these projects' data. It takes a village to manage one case of retinoblastoma, and we've been doing this for over 50 years at Wills Eye Hospital. For those of you very interested in this topic, we wrote a nice review article on modern treatment of retinoblastoma in the Indian Journal of Ophthalmology 2020. So we're going to talk about 3 topics: chemotherapy for retinoblastoma, unilateral sporadic retinoblastoma, and retinocytoma risks. For retinoblastoma 2021, it's all about chemotherapy, various delivery methods. So let's talk about chemotherapy for retinoblastoma. The management of retinoblastoma still includes enucleation, especially if there's no hope for vision, or the child looks like they have high-risk retinoblastoma, or if the parents are unreliable and chemotherapy is not available. Intravenous chemotherapy is used when there's bilateral retinoblastoma, and intra-arterial chemotherapy when there's unilateral retinoblastoma. And then for vitreous and aqueous seeds, we use intravitreal or intracameral chemotherapy. Plaque radiotherapy is still our last-ditch method for the treatment of retinoblastoma if all above fails. So first, let's talk about intravenous chemotherapy. What about it? Well, I'll ask and answer 5 questions. Does intravenous chemotherapy work? Yes, it does. Do the results vary based on the International Classification of Retinoblastoma group? And the answer is yes. Is it lasting to 20 years and even longer? Yes. Do results vary based on patient's age? Surprisingly, yes. And what features predict recurrence? Well, I'll let you know. So if we look at intravenous chemotherapy, it's used to treat the eyes, of course, but it also treats the brain and helps prevent pinealoblastoma, and it can be used to prevent metastatic disease systemically. Here's a young child we saw several years ago with bilateral advanced retinoblastoma with total retinal detachment, both eyes. And following intravenous chemotherapy, the retina reattached in both eyes. And she's now over 20 years old with visual acuity of 20/30 in the right eye and 20/70 in the left eye. She has no metastatic disease. But is this lasting for all patients? Well, we published in British Journal of Ophthalmology 2020, long-term, 20-year, real-world outcomes of intravenous chemotherapy in 964 eyes of 554 patients at our center. And what we found in this large analysis, if you look at groups A, B, C, D, and E, intravenous chemotherapy is really successful for groups A, B, and C with over 93% of globes saved, 78% of group D, and 47% of group E. And this is at year 1 in blue. And look what happens at year 2. It's about the same. And at year 3, it's still about the same. And at year 5, the same. 10, the same. 20, the same. So basically what you have at year 2 or 3 is going to be lasting for 20 years or more. Now, how often with intravenous chemotherapy do we have to use additional intra-arterial chemotherapy or plaque radiotherapy? So again, per group, A, B, C, D, E, we can see intra-arterial chemotherapy is used in about 20% of cases, and plaque radiotherapy, again, in about 20% of cases. The IAC is used at a mean interval of 5 months and the plaque at 13 months because we usually go to IAC before we go to plaque radiotherapy. So IAC overall, 17% of cases, and plaque radiation overall, about 19% of cases to save the eye. Now, what are the risk factors for tumor recurrence following primary intravenous chemotherapy? This was an analysis of 869 eyes. When does recurrence happen following intravenous chemotherapy? Well, we looked at this and we found at year 1, 2, and 3, we find most of our recurrences. It's very unusual to see recurrence after 3 years of age. So I tell our patients, if we can make it to 3 years of age with minimal or no recurrence, odds are we're not going to see recurrence even up to 15 years of age. And the risks for recurrence include younger patient age, greater class on the International Classification of Retinoblastoma, closer proximity to the disc, and the presence of subretinal seeds, each with a minor impact on recurrence. So how about IAC, intra-arterial chemotherapy? Well, we think it's best for exophytic retinoblastoma, especially if you can see an area where there's no tumor, because the tumor can shrink to a small scar and the retina usually reattaches. This is after 2 doses of intra-arterial chemotherapy using melphalan. So we're coming out in the Journal of the American Academy of Pediatric Ophthalmology and Strabismus 2021, our review of our experience, intra-arterial chemotherapy for retinoblastoma in 341 consecutive eyes, 1292 consecutive infusions. Here's an example of a boy who had group E retinoblastoma before A and B, and then after C and D, 5 cycles of intra-arterial chemotherapy. The tumor beautifully regressed and the retina was flat. I have to be honest, he did require additional intravitreal chemotherapy. So if you look at this Kaplan-Meier plot, we look at 5 years follow-up. Group B has 100% globe salvage. Group C, 80%. Group D, 78%. And Group E, 55% globe salvage. Now, these are unilateral retinoblastomas that I'm highlighting here. And this is 5-year Kaplan-Meier results. So we do pretty good with Group B and C, and still pretty good with Group D. We're saving almost 80% of the eyes, and only 50% of the eyes with Group E. So overall, globe salvage was 76% by 5 years. Median 3 infusions, and complications once you get to be good at this procedure is only 1% per infusion. Now, what about intravitreal chemotherapy? Well, here you see before intravenous chemotherapy, then after intravenous chemotherapy, we still have vitreous seeds. So we give intravitreal chemotherapy and all the seeds clean up and we're left with a fovea. And this was the child's only remaining eye. So when we published on 192 consecutive injections, we found 100% tumor control. I don't think I've ever published a paper where we had 100% success, but this is the one paper where it was. And then we did a 10-center collaborative effort where we looked at risk for extraocular extension in eyes with retinoblastoma that get intravitreous chemotherapy, and we found no case of extraocular tumor extension. So Dr. Feroz Manjan-Davida and I published this nice article in the Indian Journal of Ophthalmology recently on the role of intravitreal chemotherapy for retinoblastoma. Now we use what's called precision intravitreal chemotherapy, where we actually give our injection right to the seeds directly using indirect ophthalmoscopy guidance. And we only do this when we have localized seeds. So for example, for this seed really close to the fovea, we deposit our chemotherapy with the indirect right there. We don't shake the eye. We position the head so that the chemotherapy stays there. And as you can see on follow-up, all tumor is gone and the fovea is looks actually in good health. Now, a few words about unilateral sporadic retinoblastoma. Previous publications have noted of unilateral solitary retinoblastoma, 85% have somatic mutation, but 15% have germline mutation at risk for a host of other problems. But really, it's more than that because it depends on the baby age at presentation. So we looked at 482 consecutive patients with one tumor in one eye to ascertain the percent with germline mutation based on age at presentation. And what we found in this comparative analysis based on age at presentation, 0 to 1 year, 1 to 2, 2 to 3, and more than 3 years. Those at greatest risk for germline mutation were those who come in with, again, solitary unilateral retinoblastoma, one tumor, one eye, but they're 0 to 3 months of age. They have a 61% chance that they're going to demonstrate germline mutation and get more tumors, bilateral tumors, pinealoblastoma, and second cancers. Then it drops for the 3 to 6 month, 6 to 9, and 9 to 12 months. It's about a 20% risk for germline mutation. Then it drops down to less than 20% or less than 10% for the older children. And we're publishing this in the Journal of Pediatric Ophthalmology and Strabismus in the next few months. And then a word about retinocytoma. What is the risk for transformation into retinoblastoma? Here's an example of retinoma and retinocytomas, benign variants of retinoblastoma in 6 different patients, none of which were treated and none of which showed growth into retinoblastoma. But there is a real risk. And we looked at 78, this is the largest series ever published, 78 tumors, retinocytoma, retinoma, and the rate of transformation into retinoblastoma over 20 years. So at 5 years, it was only 7%, at 10 years, 11%, and that persisted to 20 years. So I tell patients there's about a 10 to 11% risk that a retinocytoma retinoma might transform into a retinoblastoma and need treatment. Here's an example that we recently saw. A young child from Virginia came in to see us and has an obvious retinocytoma with surrounding RPE loss, but a viable retinoblastoma sitting right in the middle of this tumor. We shrunk that away beautifully with intra-arterial chemotherapy. So these patients need to be followed just like retinoblastoma at least twice yearly for life. This will be published in the Journal of the American Academy of Pediatric Ophthalmology and Strabismus later this year. So last, just a comment. How do we feel about retinoblastoma? How does the patient feel about retinoblastoma? Well, a nice study out of India in the Indian Journal of Ophthalmology 2021 looked at this. They looked at 4 aspects of a child's health: their physical, emotional, social, and school domains. How are they doing if they have retinoblastoma? And they found that the quality of life of retinoblastoma survivors was significantly lower compared to sibling control in all 4 domains, but mostly in the physical domain, and next, the social domain. So kids aren't really doing that well with retinoblastoma, and we have to keep this in mind when we see them. Get psychologists involved. Okay, another question. How do we feel? How do the parents feel? Well, we did a nice study on depression, anxiety, and stress in parents of patients with retinoblastoma and published this in the American Journal of Ophthalmology. Our conclusions: the majority of parents display some degree of depression in 73% of cases, anxiety, 64% of cases, and stress, everyone. Severe depression was more often found in those children who have multifocal disease and previous history of depression and less education. So in summary, we've looked at retinoblastoma 2021, the various types of chemotherapy that we use, whether it be intravenous, intra-arterial, or intravitreous. We talked about unilateral, sporadic retinoblastoma. Watch out for those young babies, 0 to 3 months old. And retinocytoma carries that 11% risk for transformation into retinoblastoma. And lastly, we looked at the psychology of retinoblastoma. How are we doing? Well, we're doing well with tumor control, globe salvage, and life salvage for retinoblastoma, but we have a lot of work to do on the psychological status of the patient and the family. So retinoblastoma 2021, saving lives and saving eyes. It takes a whole village to manage one child with retinoblastoma. Thank you.
I think that was, as usual, a beautiful talk by Dr. Shields, and I hope there are audience who are listening to it and getting benefited. Welcome back, Dr. Kasturi. Mr. Vinod, do we have any questions from any of the audience, delegates, panelists? Because I'm not having access to it.
We both have the same access, ma'am. And as far as I can see, we don't have any questions for this session. So in case anybody who's live may want to ask.
Okay, that's good. So Dr. Kasturi, do you have, so I have 2 questions for you. Number one is that we mentioned about the fat transpositioning in cases of moderate to severe, lid lengthening. So what is your take on people who don't want to do fat transpositioning, but want to go with the conventional Bleph plus minus the smash lift, and later on do the filling with, fillers, because people may prefer that? And second question is, in the same league, is that do you often check the lid laxity in all the patients and make sure that there is no lid laxity on table and pre-op, so that it can be done irrespective of whether it's moderate to severe lid lengthening? Because personally, I feel that most of these patients, unless they are very young, do have mild to moderate amount of lid laxity, which needs to be addressed with lateral canthopexy or plasty plus minus mass lift.
Shubhra, that's a very valid question. Like, do we need to go for transposition in every case? Yes. I don't think, like, if I feel that even if you excise, it gives a very good correction in the initial 1-2 years. So that's a very nice, it's so easy and so fast surgery. And everything you can finish up. And most of the patients, since we do under local anesthesia, they're very comfortable. Like, we do both the lids together, so half an hour it is being done. So that is also a good option. But if you find that as you follow the patient, you should be sure that the patient is under your care and keeps on coming to you. And only if the patient gets conscious. It is not necessary that we have to point out that, yes, you have a tear trough. Only if the patient gets conscious and is not liking it, like some of my patients who are coming now, like after 4 or 5 years of the operations, they're saying that this, I'm having a little more of the pigmentation here. So these are the patient I'm going for filler. But if you have someone too much of negative vector, like someone you see total, hypoplasia of the maxilla and also too much of bone resorption. So those are the patient, I think, on the table and the same sitting, you can do a transposition. But generally, anyone below 50, 55, I don't think it is necessary. And the second question was regarding, what was the second question?
The lid tightening.
Yeah, lid tightening, what we see that along with the bags, we see some lid retraction. So lid retraction can be managed very well with an internal cantopexy. But one advantage of doing a transcutaneous, like now what I also do, I start all transconjunctival, but always I remove a pinch of skin. So one advantage of doing a transcutaneous is that you can excise the excess amount to the skin. You can do a cantoplasty, which is a much permanent result than a cantopexy. And also you can see how much amount of transposition you are doing. And in the same sitting, you can also pull the soof and smash and suture it. So if you have, without using cautery, that is the only difficulty, because externally we should not use cautery, otherwise it might lead to further lid retraction. So if you are too much a cautery user, then better you go by transconjunctival approach, then you excise it laterally. But if you do not use much of cautery, then the transcutaneous is a wonderful technique.
Also, have you seen any redistribution of the fat along the lower eyelid after 6 months, 1 year of your lower lid blepharoplasty, especially if you have not transposed the fat? Because at the end of it, fat is just one single layer from top to bottom. And I personally have seen a lot of redistribution of fat, especially the lateral compartment, no matter how much we remove, how much we retrape. What's your take on that? Because I have started counseling patients on same and say, you may need a touch-up procedure, you may need a filler, because this is what I have understood, is that there's a lot of redistribution happening in that area, especially. And sometimes there is, you feel that you have done a good job and you do good job for, let's say, 6 to 8 months, and patients do come back. Have you experienced something like that in your lower?
The hollowing or the redistribution that we see, it is mainly in the lateral part, post blepharoplasty. Centrally, you don't see, because the medial fat, whether it's in the upper lid or it's a lower lid, it never undergoes resorption, or it does not never undergoes. It keeps on increasing. Like today, there was a very beautiful presentation by Don Kikawa. He was showing this as we age, all the fat will go, but the medial fat does not go. So, but in my cases also, I have seen the hollowing basically occurring in the temporal part. So yes, these are the situations where you need to give a filler. But filler, I have seen surgeons giving filler at a very early stage. But here I want to say that never let the filler mix with the blood, the hemosiderin, because that pigmentation does not go off. It may take years to go off. So better you give some time, number one. And secondly, also with so much of tissue growth and new blood vessels coming, the chance of vascular complication is much more if you inject filler within 3 to 4 months of the surgery. So better wait around 6 months and you go for filler. That is also a very good option.
Yeah, I agree. I think we have to give specific time gap between, if you're doing fillers. I usually wait for 8 to 10 weeks, not before that. And always tell the patient about the secondary pigmentation. So thank you.
Blepharoplasty filler patients are very happy patients.
Yeah.
More than when we go for the tear trough, I think the post-bleph are the happiest people when we go for filler injection, augmentation.
Because I think some amount of laxity of skin and grade 1 to grade 2 fat is always there. And I have seen a lot of lymphatic issues happening of late, a lot of facial swelling, no matter which layer you're putting the filler. So I think we have to be very, very, and that's the advantage of being a surgeon, is that you can play around with different technologies, techniques, and products around. So to give the best result to the patient. Thank you so much, ma'am. As I said, it was an honor to have you, and I wish we could do this course physically, because we had much better plans to document, to demonstrate the techniques, have live hands-on and stuff like that. But hopefully we'll have it next year in a big grand way.
Yeah, next time if we have it, we'll definitely go for live demonstration during the IC.
Yeah. And thank you, Vatsalya. I think you did a wonderful job with your, under the guidance of Dr. Kasturi. Thank you so much. Thank you, Mr. Vinod, and all the technical teams. And I see Feroz.
Excellent presentation, Shubhra. I was in and out
I know.
in other halls in here. Yeah, excellent.
I understand you guys are doing a mammoth job and doing so wonderfully. And all the best. And thank you for this opportunity. I thank all the panelists who were there on board and the delegates, if any, who were listening to us. But it's always an honor and pleasure to talk about what you love the most amongst the best in the country. Thank you so much.